all. Welcome to our September edition of our TB Think Tank webinar series, which takes place on a monthly basis. This session is titled Simultaneous Initiation of 12-week isoniazid and rifapentine-based TB preventative therapy and dolutegravir-based antiretroviral therapy in treatment-naive people with HIV. A brief introduction of our presenter today. Dr. Ethel Welt is an assistant professor of medicine, pharmacology, and molecular sciences at the Johns Hopkins University School of Medicine, where she also serves as an infectious diseases attending physician on the HIV/AIDS service and the General Infectious Diseases Consultation Service. She has received her medical degree from the University of Chicago and a PhD in clinical investigation from the Johns Hopkins Bloomberg School of Public Health. She is trained as an internist pediatrician and completed additional postgraduate dual subspecialty training in clinical pharmacology and infectious diseases. She is now a clinician, scientist, and clinical trialist, specializing in the clinical pharmacology of anti-infective medications. Her clinical research focuses broadly on improving options for the treatment of tuberculosis in children and adults with HIV and improving prevention options for people with HIV living in settings with a high prevalence of TB. Over to you, Dr. Ethel.
Thank you so much, Nawazi, for the kind introduction. I will share my slides and get started. Are you able to see my slides?
Yes, we are.
Yes.
Doctor.
Okay, beautiful. Well, it's my great pleasure and honor today to present to you the results of the Dolphin 2 study, which was performed in South Africa at the Orem Institute. A bit of trouble advancing. There we go. So I have no current disclosures relevant to this talk to report to you, and here are the acronyms I will be relying on for the talk. And I just wanted to start by saying a quote that someone drew my attention to, which is that something that is prevented is a non-event. So it's low drama and escapes notice, and as a consequence, the benefits of prevention are more likely to appeal to our intellect than to our emotions. However, I think that everyone on the call can appreciate that an ounce of prevention is worth a pound of cure. So on this talk, I'll be talking a bit about some background, the Dolphin study, that was the first phase of this study, also conducted at Orem. I'll speak to you about the Dolphin 2 study and a few considerations surrounding its results. So the Dolphin study, which Kelly Dooley published in the Lancet HIV along with colleagues displayed here from Orem, was a study of rifapentine and isoniazid once weekly, so the 3HP regimen for TB prevention in virally suppressed people with HIV who were asked to complete an efavirenz washout for 8 weeks and then started on 3HP while taking once daily dolutegravir along with TDF and FTC. And the study was interested in the pharmacokinetics of dolutegravir because, as you know, and as is depicted in the upper right-hand box, the metabolism of this drug is primarily through the UGT1A1 enzymatic pathway, and then there's some secondary metabolism from CYP3A4, and rifapentine is a notorious inducer of both of those pathways. And indeed, the study showed that the pharmacokinetics were affected. Rifapentine increased dolutegravir clearance by about 36%, and decreased the area under the concentration time curve for dolutegravir of 26%. And the trough, which is perhaps more important virologically, was decreased by 56 to 64%, depending on which day it was after taking your rifapentine. There were 2 participants who had concentrations, 8 different concentrations measured as below the limits of quantitation for the test. And the limit of quantitation was 100 nanograms per ml. 30 nanograms per ml. And the important thing is the PK was affected, the safety was tolerable. So there were only 3 grade 3 adverse events. 2 were elevated creatinine, and 1 was a hypertensive event. But overall, this was well tolerated. There were no discontinues for treatment-related adverse events. And the efficacy showed that all participants remained virally suppressed, and that included the 2 participants with dolutegravir concentrations below the limits of quantitation for the test. So we can see on the left depiction of day 0, dolutegravir alone, the geometric mean concentration was 1,003. And week 3, after taking 3 weekly doses of dolutegravir plus rifapentine, on day 2 after that dose, the concentration, the geometric mean was 355. And these are troughs. So we do see the geometric mean ratio was about 0.53, though the ratio did indeed vary by the day after rifapentine dose. There was 1 participant who had a viral load of 2,300 copies per ml at week 24. So that's after completing the 3HP treatment. So remember, there was 8 weeks of efavirenz washout and then the 12 weeks of therapy with 3HP. That person, following adherence counseling, had a recheck viral load that was suppressed under 40 copies per ml. And overall, otherwise, the viral load measurements were under 40 copies per ml at baseline and throughout the receipt of dolutegravir plus 3HP. So I'll introduce now the DOLPHIN-2 study, which I have presented at the Union Conference in 2023 and the CROI Conference in Denver in 2024, and which has been submitted as a manuscript for publication, and we are awaiting their review. So these are the co-authors and the funders. And the short background for this study is, again, that short course TB preventive treatment with weekly isoniazid and rifapentine has very high potential to improve outcomes for people with HIV living in high burden, high endemicity settings for TB. And we know that clearance was induced by rifapentine, clearance of dolutegravir, and we know that everyone in DOLPHIN remains suppressed with favorable safety. Which was reassuring because there had been an earlier study with 4 healthy volunteers that actually needed to stop early because of 2 severe hypersensitivity reactions with severe liver adverse effects and cytokine-mediated adverse effects. So it was reassuring that in the first phase, the safety was well tolerated. DOLPHIN-2 was performed to investigate the safety and viral dynamics and dolutegravir pharmacokinetics of the simultaneous initiation of dolutegravir containing ART and 3HP among people with HIV who were antiretroviral naive, so who had not previously received treatment for their HIV. And there was a dearth of data on simultaneous initiation before we did this study. And there was some concern that the coincident or the concurrent initiation of these 2 therapeutics would be in some way perhaps have unfavorable safety or perhaps result in iris events or et cetera. So I think there was some concern that it was important to investigate this before this became widespread practice. So there was some previous data on initiation of 3HP programmatically 2 to 4 weeks after the dolutegravir-based ART. So after someone had become suppressed with dolutegravir-based ART, starting the 3HP, but the simultaneous initiation was for the first time the focus of this study. And this was a phase 1 and 2 comparative trial of 3HP with a comparator group of 6 months of isoniazid, which was at the time the South African standard of care, among antiretroviral naive adults with HIV initiating once daily 3-drug ART. So no evening dose of dolutegravir, just once daily dolutegravir-based ART. The participants were sequentially enrolled, and the era was August 31st, 2021 to June 28th, 2022, which does cover some of the most severe periods of pandemic. So really noteworthy that the study team was able to enroll, and the ORM team was really fantastic at doing so. And the primary endpoints were safety and dolutegravir pharmacokinetics during the co-administration of TPT and dolutegravir-based ART. Secondary endpoint was viral load at various time points, but at the end of 3HP and then 3 months after that at 24 weeks post-entry. And we did employ nonlinear mixed effects modeling to estimate the effect of rifapentine on dolutegravir clearance and model the trough concentrations of dolutegravir. This was our pharmacokinetics sampling scheme. So the yellow arrow represents where the particular treatment was begun. So dolutegravir-based ART was begun on day 0, and then a trough was sampled on day 1, so pre-TPT, and then TPT in both groups would have begun on day 1 with pharmacokinetic sparse sampling performed 3 days after the 3rd and 8th dose of HP, so on day 17 and then day 52. Viral load measurements were taken throughout. And we did enroll 75 participants after screening 132. The reasons for exclusion are depicted in the right-hand bubble. And then in both groups, we had some loss to follow-up. There was a participant in the 6H group who was incarcerated and 2 who were either lost to follow-up or relocated. And then in the 3HP group, several who withdrew or relocated or were non-adherent to study procedures. There was 1 participant who, after the week 16 visit, was withdrew due to pregnancy. So these are the participant characteristics for the Dolphin-2 study. You can see that it's overall a young population with a median age of 35 years, with an interquartile range of 27 to 41 years. About half were female. There was a fairly, the median BMI was 23.7. 23% of the participants overall had a quantiferin plus that was positive at baseline. And the baseline viral load varied overall from about 7,000 to 111,000 in terms of the interquartile range, with a median of 27,000 at baseline. But 27% of participants had a viral load in the 100,000 to 1 million range. And about a quarter of the participants had a CD4 count at baseline under 200. And this is the safety. So you can see that overall in the 6H group, there were 11 unique participants with adverse events, 25 adverse events of all grades. In the 3HP group, there were 14 participants, unique participants with adverse events, and there were 19 adverse events in that group. And if you look with the red box at just the treatment-related adverse events, you can see that there were 9 in the 3HP group and 3 in the 6H group, but for the most part, mild, grade 1 or 2. The study endpoint of grade 3 or above treatment-related adverse events was not reached in any participant. So the primary endpoint was not met, which was a good thing, meaning there was not any grade 3 or above AE that was seen. There were no iris events and there were no AEs that resulted in drug discontinuation. And looking only within that red box at the treatment-related adverse events, just to see what they were, you can see them depicted here. In this table, I have adverse events that were attributed to the ART and attributed to the TB preventive treatment, both displayed. So you can see that the AEs that occurred in the 6H group that were attributed to TPT were 0, whereas there were 9 unique events attributed to TPT in the 3HP group. But these, many of these happened in the same participant. There was one occasion of hyperbilirubinemia, and there was an occasion of ALT and peripheral neuropathy symptoms that occurred in the same participant. So this was overall encouraging. Nothing met criteria for Hy's Law. No one had to have their regimen stopped because of AEs. Here is the viral load results. So the primary endpoint of HIV RNA under 50 copies per ml at week 12 and week 24 is in the red box. You can see the columns represent FDA snapshot algorithm, viral suppression proportion, and in the beige colored column, this is the complete case analysis for the number of viral load test results that we had available, how many were suppressed, because we did have some participants with testing that was not available. No test result was done. So you can see that by 8 weeks, 22 out of 25 participants, so 88%, had a suppression under 50 copies in the 6H group, and 47 out of 50, so 94%, had viral suppression under 50 copies in the 3HP group. And then the numbers in this very busy table otherwise generally show a trend towards when we did a complete case analysis of all the test results that we had available, 100% were suppressed in the 3HP group at week 12, and then 96% were suppressed in the 6H group at week 12. These are the viral dynamics over time. So the y-axis is HIV viral load. The x-axis is time in weeks after study entry. The teal color is the participants in the 3HP group. The salmon color is the participants in the 6H group. And you can see by the yellow arrows where the various therapeutics were begun and ended. Overall, there was a robust drop in viral load. The median viral load decline from study initiation to week 12, which was the end of 3HP, was 4.3 logs in the 3HP group, 4.8 logs in the 6H group. And we did do an analysis for those who did have some missing HIV viral load data and carried forward the last or most recent viral load that we had for those participants and assumed that it was the same at a subsequent time point. So if they had suppressed under 50 copies at week 16, we also assumed they had suppressed under 50 copies at week 24. And if there were 300 copies at week 16, we also assumed they were 300 copies at week 24. And then you can see that with that analysis at week 24, 48 out of 50 would be considered virally suppressed in the 3HP group, and 23 out of 25 would be considered virally suppressed in the 6H group. This is a plot of the dolutegravir trough over time. The median is the heavy line through the box plot, and the whiskers represent the 90% prediction interval for the dolutegravir troughs. The horizontal red dotted line is the somewhat arbitrary, perhaps, mark of the 5th percentile of the trough that was observed in the Spring 1 trial with 10 milligrams of daily dolutegravir, which resulted in viral suppression that was equally robust to when participants received 50 milligrams of daily dolutegravir. So that's 158 nanograms per ml. And for the most part, concentrations minimal concentrations of dolutegravir were above that limit. And you can see that nonlinear mixed effects modeling showed a 72% induction effect of rifapentine on dolutegravir clearance. So the clearance went from 0.954 liters per hour to 1.64 liters per hour, while keeping in mind that our sampling represented the worst case scenario for rifapentine induction on dolutegravir levels. So we were sampling at 3 days after the dose, which in modeling has been shown to be the time of maximal induction post rifapentine. In the chart at the bottom, you can see the number of participants who were below various cutoffs, and you can see those 2 participants who were below 158 nanograms per ml. None in either study group were below 64 nanograms per ml, which represents the protein-adjusted IC90, the concentration at which in a test tube 90% of viral strains are killed. So we did look at those 2 participants who had lower levels. We didn't have anyone below the PAIC90, but we looked at the people who were below this 5th percentile measurement that was seen in a previous trial. And we saw that they both had suppression to under 50 copies per ml by week 8, despite having those lower dolutegravir concentrations at week 3. So the first one dropped from 290,000 to 47 copies per ml over the first 8 weeks of the study, and the second dropped from 37,000 to under 40 copies per ml, and they both maintained and achieved viral suppression thereafter. Their troughs are displayed below. So what we concluded from the Dolphin 2 study was that simultaneously initiating 3HP TB preventive treatment and once daily dolutegravir in individuals with HIV who are antiretroviral naive was safe and achieved and maintained rapid viral suppression, so 4 logs in 12 weeks, with robust dolutegravir troughs, and that there were similar high rates of viral suppression in both groups, in the group that contained rifapentine, 3HP, and the group that did not, the 6H group. We did observe, excuse me, a 72% induction effect of rifapentine on dolutegravir clearance, resulting in lowered dolutegravir troughs, and they were significantly lower in the 3HP group than the 6H group at weeks 3 and 8, but still sufficient to achieve and maintain a viral load under 50 copies per ml. And it was rare to see troughs really in this lowest region under the 158 nanograms per ml arbitrary cutoff, but there was a rapid drop in viral load at 3 weeks and full viral suppression seen at 8 weeks in those 2 participants who had levels that low regardless. And there was no dolutegravir level below the PAIC90 of 64 nanograms per ml in either group. So We feel that this trial provides useful evidence that could be used to inform both global and country-specific guidelines on simultaneous initiation of ART and 3HP in newly diagnosed people with HIV. We did want to just mention that when this has been looked at in the lab, so when scintillation proximity assays were performed and they looked at dissociation of integrase inhibitors from their target, the integrase enzyme, as measured by viral replication after drug washout, the half-life of dissociation of these compounds from the target is really chronologically increasing as each new INSTI is produced. So in the very bottom, we see in the red box, elvitegravir with a half-life of 3 hours from its target. Raltegravir was slightly longer, half-life of 10 hours. Dolutegravir, 96 hours. And then bictegravir, 163 hours, so almost a week. And it's been hypothesized that the fact that these later iterations of INSTI medications remain bound to their receptor for so long may mean that they can tolerate both perhaps perturbations in the binding site that could lead to viral resistance otherwise if the molecule was not bound there, or also perturbations in plasma concentrations of these drugs that could maybe be tolerated and represent more of a cushion for drug-drug interactions than with the earlier INSTIs. Just mentioning this assay has a very long methods section of many paragraphs long that was somewhat imperturbable impenetrable to someone who's a non-virologist and not a lab person. And so I think that there would be other ways to test this, just because these papers are mostly produced by stakeholders of the companies that manufacture these drugs. And I think it would be great to reproduce this and understand this for sure, but it certainly is in keeping with the findings that when dolutegravir and bictegravir levels are dropped, people still maintain viral suppression. So what target trough do we need? This is an active area of investigation, investigated nowhere more robustly than in South Africa. But I think that it's something that bears re-examination, and we may not need troughs as high as we initially thought that we did. And this is a trough courtesy of Anthony Podani, just summarizing the existing data for co-administering 1HP and 3HP with INSTIs. And so you can see there is emerging data both in the ACTG 5372 study, which looked at twice daily dolutegravir with 1 HP, so daily rifapentine for a month, and found that actually the dolutegravir concentrations were higher with the BID approach, even with rifapentine co-administered, than once daily dolutegravir administered without rifapentine, but that participants generally did very well. There's another trial out of Thailand that had results presented at AIDS 2024 of 1 HP with daily dolutegravir, and showed some lowering of trough, but that participants in general remained suppressed. And then there's emerging programmatic data, both from Thailand and also Taiwan and a lot of parts of Southeast Asia that looked at 1 HP or 3 HP along with dolutegravir or bictegravir, and actually found great viral suppression despite some trough lowering as well. And then there's these two phases of the dolphin study, both Kelly Dooley's previously published dolphin study that was conducted at Orem, and this study that I've just presented to you now. So overall, the data is strong for this combinatorial approach. This is what I've tried to cover today. And I did want to just acknowledge the incredible participation of the study participants and their communities of support, their families, the Orem Institute for really doing an incredible job with this study and under very trying circumstances and conditions. Lisa Wolf, who did some initial preparation for the study and was really a key actor in making sure that everything went forward. And then my mentors, Dick Chason and Kelly Dooley and Gavin Churchyard for leading things at Orem, and our funding, which came mostly from Unitaid, the Impact for TB project, and then some supplemental funding provided by Vive Healthcare. So I'll stop sharing there. It's a bit early, but I thought we could take any questions that occur to people.
Thank you so much for your presentation, Dr. Welt. As mentioned by our presenter, please do enter your comments or questions underneath the Q&A tab at the top of your screen. Do we have perhaps any comments or questions from the Secretariat?
Yes, thanks, Noazi. It's Bazana here. So I just have one question. So in the trial DTG, okay, well, so DTG is administered daily, and the 3HP is administered weekly. Would you think that those differences in the dose frequency would have an impact on adherence? And was some work, possibly qualitative, looked at in the study to get some feedback like that from the patients?
Yeah, it's a great question. So we had adherence measured by study diaries and by kind of being in close contact with participants for the couple of days leading up to PK visits. We didn't have a separate kind of qualitative set of assessments, but it's a good question of whether it's easier, whether it supports adherence more to take something once a week or once daily. There's certainly things we remember to do once weekly. I change my filter on my furnace once a month, and I have it written on my kitchen calendar. You know, so there's things that we do every Sunday, or there's things that we do monthly. So I think we certainly are capable of remembering things once monthly, but once weekly, but I think it is less routine than taking something once a day. On the other hand, life is busy and there's other things that get in the way, and lapses are certainly possible with daily medications, as we all know. But I think there's definitely room for robust qualitative work. And I think that probably the answer is different for every person, whether weekly or daily is easier to remember within the context of their individual lives. But it seems great to have multiple different options and the choice available to you, which might fit into your life better.
Thank you.
Thank you.
Thanks, Razana. Thanks, Dr. Welt. Do we have any comments? Please enter them under the Q&A tab that you may have for our presenter today. In the meantime, I'd like to just remind everyone in attendance that if you'd like to see yourself on this very platform, which takes place on a monthly basis, Do send myself an email at ngosi@tbthinktank.org. Yeah, if you'd like to see yourself presenting on this platform.
There's a question, Lwazi.
Yes, thank you. The question goes, Doctor, would this improve the patient experience, and what investment is needed at the district level?
Yeah, that's an important question. So will it improve the patient experience? Probably depends on the patient. What I would say is if you're initially presenting to care, so your HIV has not been treated yet, getting on ART immediately is essential for your well-being, and that I think gets strongly messaged by most providers and most clinics. And I think TPT is seen as something that can wait, that can come later. It's just something that we're preventing, we're not treating. You know, these people don't have active TB yet, so we'll just wait for that. But actually treating it as much of an emergency as getting on ART, I think is actually quite smart, because it's something that doesn't get pushed aside for the future or for the time when someone else will get to it. I think it actually is going to result in greater uptake of TPT. And then with these shorter regimens, they're achievable in a much shorter period of time, which, as we know, duration is inversely proportional to treatment completion. So I think that it's important to know that, you know, immediate initiation is one of the options. It's something where someone is engaged in care, being monitored closely anyway because of the initiation of ART, and it's in some ways the safest time that there is for getting the TPT out of the way. And again, you know, people who have not yet accessed treatment for their HIV are at the highest probability and risk of progressing from latent TB infection to TB disease and its complications, including death. So I think it's actually a way to probably prevent mortality from TB. And in terms of the patient experience, it's a streamlining of care. It's not kicking the can down the road to a later time in the future. So I think those are favorable things. I'm so sorry not to know a ton about what investment is needed at the district level. I'm sure that there are people on the call who might be able to answer that much better than me, because I'm not familiar with some of the ways that things are programmatically and operationally implemented in South Africa. So I'm happy to hear people's input about what is needed at the district level. And then I'm looking at some other questions. So were there community advisory boards involved in these studies? And if so, were they effective for adherence? That's a great question. I think we did have a community advisory board initially that kind of advised us on study design. And I think that there was not kind of an ongoing longitudinal involvement of the CAB for assessing or supporting adherence, but it's a great idea for future studies. So I think this question is really just confirming, are we saying that same day initiation of ART and 3HP is not a problem from a viewpoint of dolutegravir levels and viral suppression? Yes, that is exactly what we're saying. So that is what this study looked at. Now, did we look at millions of patients? No, we looked at 75, but we are definitely reassured by what we found in those 75 participants, or in the 50 that were on 3HP. And we are privileged to be able to have emerging programmatic data from South Africa and all over the world that is showing us that even though the integrase strand transfer inhibitor levels get lowered by concurrent rifapentine, it is not an issue for achieving viral suppression in people who even have quite high viral loads of in the millions. So these are still providing robust viral suppression despite the trough lowering. So that's what we were interested in, and that's indeed what we showed. And I think keeping our eye on the programmatic data as it emerges is going to be essential. But I think initially people had reservations based on that healthy volunteer study, first author Brooks, which showed this occurrence of hypersensitivity type reactions in 2 out of the 4 participants that were really quite scary. And people thought, oh, well, maybe this combination is not safe in some way, but that's not what we saw. And I think what we can conclude is that studies really need to be done in people with HIV before we conclude something about their safety in people without HIV. There can be different findings in kind of those 2 study populations. Okay, so let me just read this question. We've been undertaking treatment literacy work as part of these trials on the Impact for TB project, working with affected communities and NGOs and National Treatment Program work on community-led monitoring for TPT. And we've seen an increase in demand for rifapentine-based TPT despite the SAEs. So I think that you mean the concern about hypersensitivity reactions from previous trials, or do you mean that you're actually in the rollout seeing a lot of SAEs? Because that would be important to know. But despite the SAEs and other socioeconomic factors, and the reduced pill burden has really helped as well. And that's essential. That's an essential consideration because you're taking your dolutegravir-based ART, and you're definitely taking that every day. So having one less thing to take every day is really going to help you be able to achieve adherence to the other set of medicines. And I think getting pill burden down is essential for patients. Thank you for a very informative presentation. Thank you for listening. Would it be beneficial at all for a patient to add in an additional dose of dolutegravir as NTB treatment on the day that 3HP is taken? It would be great if we can start implementing this as we're struggling with covering enough HIV positive patients with TPT. And 3HP is a very user-friendly regimen we have found in patients initiated on it. Thank you so much for that information and perspective. So in terms of whether we need to do twice daily dolutegravir, either longitudinally or just on the day that rifapentine is taken. So the approach of doing an extra dose of dolutegravir just on the day that the rifapentine and 3HP is taken has not, to my knowledge, been studied. But I think what we tried to study here is a simple, just take your once daily dolutegravir and take your 3HP once a week. And no other adjustments besides that were done. And people still had robust viral suppression. And though the troughs were a little bit lower, they were enough. They were good enough to maintain or to achieve and maintain viral suppression throughout the study for people who were getting both of these together, 3HP and dolutegravir. And I would just argue that good enough is good enough. And adding more complicated instructions is maybe something that will have the kind of backfiring effect of making things more complicated and making room for adherence lapses because of just how complicated the regimen can get. So I think it's a great thought, and it's reasonable to think of studying it, but we studied this combination without doing that extra dose, and it was fine. And then I would love for this to start being implemented in people who come to care who have never been treated for their HIV before. I think it would be great to implement it. And I think what I've heard about uptake is that it tends to kind of be better tolerated, and uptake actually tends to be improved when pyridoxine is offered alongside the 3HP regimen, which makes sense for any isoniazid containing regimen. And you saw that there were some peripheral neuropathy adverse events in our trial, and that would be something that could mitigate that. That's one operational consideration for something that is, I think, fairly cheap. But it's great that you're finding this to be a user-friendly regimen. And then, so you're pointing out that the SAE slides with the 4 quadrants are telling, as these are the same data we've been getting from, I'm not sure what PHC is, in the focal countries. Communities have been reporting these. So I think what you're saying is that communities have been reporting that there are some adverse events with the 3HP regimen as compared to with the 6H regimen. I think one of the questions is the adherence to the 6H regimen. So are people actually on the isoniazid when something's taken once a week, sometimes with clinic supervision? Then adherence is in a way ensured, but when someone's just told to take daily isoniazid, it may not be so clear. So it's possible that kind of the burdens of daily isoniazid over a 6-month period in complex and busy lives lead to some lapses in adherence, and that we're not really comparing apples to apples in terms of whether the drug is actually being ingested. It is also possible, and we did see that there's a slightly higher rate of these grade 1 and 2 mild AEs with the 3HP regimen than with the 6H, but you're only taking it for 3 months. And most of these were mild and self-limited, and often not, they were laboratory abnormalities that then resolved, that were not necessarily something that would rise to the level of perception by the patient themselves. So I think this is actually a question that could use some qualitative work itself. Would you prefer a few AEs that are mild and self-limited over a shorter period of time, or would you prefer to take another medicine for months on end? And obviously, decisions need to be made at a higher level about what is going to be going forward as the most implementable regimen, 1HP, 3HP, etc. But I think that these questions are essential to try to get at. We were not seeing severe AEs or grade 3 AEs, but it was really all in the milder range. And I believe that this data also applies to 3HP fixed dose combination. I do. I don't see that there would be a difference between separated out isoniazid and rifapentine and combined. A measure of the impact of if the 3HP dose was not taken on the exact same day of the week every week, like it was Monday last week and things got in the way and it was Wednesday this week. No, I don't have a measure of that impact, but I think I could ask colleagues at Orem to provide information on whether there was any slippage like that. But for the most part, it was scheduled dosing on defined study visits. But I think that's an important question. Is the bringing forward of viral load and those not followed up a conservative approach to loss to follow up? Thank you, Prof. Martinson. I think that it depends on what you mean by conservative. So I think that we kind of wanted to understand what had happened at the most recent time point for people who moved away, were you know, not reachable, were not testable. What had happened to them right before they were lost to follow-up. So we thought that the bringing forward could be considered a reasonable approach to give us at least some representation of what their recent kind of viral history had been. I think that, you know, this is not necessarily an approach that is routine, but it's just, you know, this particular population of people who are antiretroviral naive and have not yet accessed treatment may represent a population that is a bit hard to reach, and, you know, might have more issues in accessing care and perhaps falling out of follow-up than other segments of the population. And I think we definitely saw some loss to follow-up in our trial and had to try to think of ways to accommodate it. But I mean, I think if you assume that at the time point before they were lost to follow-up, they actually had been, you know, not yet suppressed. So they had a viral load of 3 logs, and then you bring that forward, then it is kind of a conservative approach in that setting, because you never know, you know, at week 4, they might have completely suppressed. They weren't in care, so you couldn't test it. And so I think bringing forward the viral load, no matter what it was at the more recent point, is a kind of an agnostic way of doing it. But I'm very open to your feedback on whether it's conservative or not. I don't have data on the Dolphin Kids trial yet, but it is coming. Supply constraints of rifapentine in anticipation of program adoption. Unfortunately, that's not my area of expertise, and I don't have comment, but I'm sure that there's expertise on this call that can comment on that. So people should feel free to type answers to that. Okay, so let's see. The differentiated service delivery models work for people living with HIV for uptake, but not so useful for TB affected persons and TB contacts, as they are scared of being screened and there are threats of taking meds when TB contacts feel healthy. Okay. Scared of being screened. I mean, I think one thing we could do is just kind of normalize and routinize the taking of TPT. You could say we are fortunate to live in this breathtakingly beautiful part of the world where there is a high burden of TB, and it's as routine as taking, you know, vitamins. Like routinizing it is a way to get away from the stigma of being labeled and being kind of brought to the attention of the public health authorities as a threat or something like that. So I think routinization is one way to get around that. And differentiated service delivery models, I think, are really interesting, and I want to know more about them as a model. For demand creation, communities are reporting data on issues such as stigma and discrimination, including the catastrophic costs of TB. Okay. Now we are seeing significant issues with insufficient knowledge among healthcare workers on TPT. They do not have sufficient training. Yeah, so TPT is a way of, even though prevention is a non-event, it is a way of decreasing the catastrophic costs of TB. So I think that preventing TB is the most important way to do that. In terms of insufficient training, I think that training is important. I think that, maybe some programmatic training for community health workers will go a long way. And I think that also drawing from the vast experience of people who are trying to implement this technology is essential. So people who are actually trying to implement this are the true experts in what the barriers are and the issues are. But I think everyone should get some training. However, I also think that it shouldn't be made to seem as too threatening, this strategy, because when we've looked at it, it's well tolerated, safe, and effective. So, perhaps a little bit of disseminating those results might go a long way. But I think that is the last question. And I really, oh no, here I see. Okay, to clarify. People living with HIV are okay with being initiated immediately. I'm assuming that means on ART or on TPT. For people affected by TB, this is a challenge because we do not have affordable or accessible diagnostic tools for TB infection. And I think what the data has shown is you don't necessarily need to test everyone with quantiferon gold plus. I think treating people without that test result is a very reasonable public health approach and one that is recommended by global guidelines. And I think that, using as your tool the routine provision and offering of TB preventive therapy at the moment that people are initiating their ART, that's one of the most important tools we have before people do relocate to another place, move to another country, get a job and travel, and are lost to care. So I think this is a window of opportunity to use the two together, and that's an operational consideration that's important, even without diagnostic tools for TB infection. The fact that someone is living in a high burden setting for TB and has HIV is enough. So I'm just trying to see, I think that might be the last question, and thank you for these incredible questions, and I've tried to do my best with them, but I think that there's lots of room for, innovation and more learnings surrounding some of these very critical questions that you have raised. So thank you. I really appreciate your listening today, and I'll turn it over to Nolwazi.
Thank you so much, Dr. Welt. I'll reiterate what you've just said. Thank you all for attending today's session. Thank you, Dr. Welt, for your time and your presentation and the very insightful presentation at that. I'd just like to say to everyone, do enjoy the rest of your day. Thank you.
You too, and thanks everyone for trying out the day. It seems like it's a good day. I'll go forward at 7 a.m. So I'll continue on with my day, but thanks for trying it out for me. All right, take care.
Bye.